Okay, good afternoon, everyone. You can see my slide now.
Yes po, Doc.
Yes po, Doc.
So we're done with the drugs for hypertension as well as drugs for angina. So for this afternoon, our lecture will be on the drugs used in heart failure. So heart failure occurs when your cardiac output is inadequate to provide the oxygen needed by the body. So based on the statistics, the 5-year mortality rate is about 50%. And the most common cause of heart failure in the US is coronary artery disease as well as hypertension. So there are two major types of heart failure. You have your systolic failure and your diastolic failure. But the current nomenclature for your systolic and diastolic heart failure now is your HFrEF and your HFpEF. HFrEF stands for heart failure with reduced ejection fraction, and HFpEF, heart failure for preserved ejection fraction. So for your systolic failure, most of these patients, or approximately 50% of patients, develop systolic failure. It is characterized by a reduced mechanical pumping and reduced ejection fraction. That's why the new name is heart failure with reduced ejection fraction, because the ejection fraction here, or your LV systolic function, is reduced. So for diastolic failure, this is usually caused by a stiffening and loss of adequate relaxation. So it's more of the diastolic dysfunction, reducing feeling and cardiac output. So the ejection fraction here is normal. That's why it's called as HFpEF, or heart failure with preserved ejection fraction. So heart failure is a progressive disease, and it is characterized by gradual reduction in cardiac performance, punctuated by episodes of acute decompensation requiring hospitalization. So treatment is directed at two different goals. One is to reduce symptoms and slow the progression as much during stable periods, and manage acute episodes of decompensated heart failure. So these are the drug groups that are commonly used in heart failure. So you have your diuretics, your aldosterone receptor antagonist, your ACE inhibitors, angiotensin receptor blockers, beta blockers. You have your cardiac glycosides, vasodilators, your beta agonists, Bipedins, and natriuretic peptides. So let's first have a short review of the physiology. And so the contraction of the heart muscle is determined by several processes, and this will lead to the movement of your actin and myosin filaments in the cardiac sarcomere. So this contraction results from the interaction of your activator calcium with the actin troponin tropomyosin system, thereby releasing the actin-myosin interaction. So calcium is also released from the sarcoplasmic reticulum, and the amount of calcium that is released depends on the amount stored in the sarcoplasmic reticulum and the amount of trigger calcium that enters the cell during the plateau of your action potential. Now, the determinants of calcium sensitivity, this is the curve relating the shortening of cardiac myofibrils to the cytoplasmic calcium concentrations, are not completely understood. However, you have a new drug, which is called your levosimendan, is an example of a drug that will increase your calcium sensitivity and reduce symptoms of heart failure. Now, the rise in your free cytoplasmic calcium due to calcium influx during action potential will trigger the opening of your calcium-gated ryanodine-sensitive calcium channels in the membrane of your sarcoplasmic reticulum, and the rapid release of a large amount of this ion into the cytoplasm in the vicinity of your actin troponin tropomyosin complex. So the amount released is proportional to the amount stored in the sarcoplasmic reticulum and the amount of trigger calcium that enters the cell through the cell membrane. So your ryanodine is a potent negative inotropic plant alkaloid that interferes with the release of calcium through cardiac sarcoplasmic reticulum channels. So the sarcoplasmic reticulum membrane contains an efficient calcium uptake transporter, which is called your SERCA, or your sarcoplasmic endoplasmic reticulum calcium ATPase, which maintains the free cytoplasmic calcium at very low levels during diastole by pumping calcium into the sarcoplasmic reticulum. So SERCA is inhibited by phospholamban. So phosphorylation of phospholamban by protein kinase will remove this inhibition. So the amount of calcium that is sequestered in the cytoplasmic reticulum is determined by the amount accessible to this transporter and the activity of the sympathetic nervous system. So it's dependent on the balance of calcium influx and calcium efflux, meaning the going in and out of calcium from the cell, and the amount removed from the cell. So via this transporter. So the amount of calcium released from the sarcoplasmic reticulum depends on the response of the ryanodine-sensitive calcium channels to trigger calcium. So the amount of trigger calcium that enters the cell depends also on the availability of the membrane calcium channels and the duration of their opening. So your sympathetic mimetics will cause an increase in calcium influx through action on these channels. So the calcium channel blockers will reduce this influx and will depress contractility. The antiporter, which is your NCX, uses the sodium gradient to move calcium against its concentration gradient from the cytoplasm to the extracellular space. Your extracellular concentrations of these ions are less labile than intracellular concentrations under physiologic conditions. And the sodium-calcium exchanger's ability to carry out this transport is strongly dependent on the intracellular concentrations of both ions, especially your sodium. Now, removing your intracellular sodium is actually the major determinant of sodium concentration in the cell. So sodium influx through your voltage-gated channels and the amount of sodium that enters with each action potential is much less than 1% of the total intracellular sodium. So your sodium-potassium ATPase appear to be the primary target of digoxin and other cardiac glycosides. So heart failure is a syndrome with many causes that may involve either the ventricle or both. So the cardiac output is usually below the normal range. So you have systolic dysfunction, and this could be in the form of an acute failure where you have reduced cardiac output, and this will significantly equivalent to a reduced ejection fraction that is less than 45%, especially in cases of myocardial infarction. So usually the cause of acute heart failure is from a massive acute myocardial infarction. So for systolic dysfunction, this usually is a result of hypertrophy and stiffening of the myocardium. So the cardiac output here is reduced, and the ejection fraction, however, is normal. So it does not usually respond to positive inotropic drugs. So another important form of heart failure is your so-called high output failure. This is a rare form of heart failure where the demands of the body are so great that even increased cardiac output is insufficient. So this is seen in conditions like hyperthyroidism, beriberi, anemia, and arteriovenous shunts. And they would respond poorly to drugs. And they should be treated actually by correcting the underlying cause. So what are the primary signs and symptoms of heart failure? So for all types, you will have tachycardia, decreased exercise tolerance, shortness of breath, peripheral and pulmonary edema, and cardiomegaly. So the decreased exercise tolerance observed in patients with heart failure with muscular fatigue is the major direct consequence of a diminished cardiac output. So there are compensations that are actually involved in heart failure. So you have your neurohumoral compensations, which includes your sympathetic nervous system or involves your sympathetic nervous system and your renin, angiotensin, aldosterone hormonal response. So in heart failure, the baroreceptor reflex appears to be reset. So you have lower sensitivity to arterial pressure. So the baroreceptor sensory input to the vasomotor center is reduced so that you will have an increase in your sympathetic outflow while your parasympathetic outflow is reduced. So if you have increased sympathetic outflow, you will have tachycardia. It will cause an increase in the cardiac contractility as well as an increase in your vascular tone. So the vascular tone is further increased by your angiotensin II and endothelin, which are potent vasoconstrictors, and they are usually released by your vascular endothelial cells. So with vasoconstriction, you will have an increase in your afterload. Thus, you will also have a reduction in your ejection fraction as well as your cardiac output. So your neurohumoral antagonists and vasodilators reduce heart failure mortality by interrupting the cycle and slowing down the downward spiral. So this is the compensatory responses that occur during heart failure. So initially, you will have some compensations that occur. So if you have a decrease in your cardiac output, it will cause a reduction in the renal blood flow. And this is sensed by the kidney. So you will have more renin release as well as your angiotensin II will be increased, causing an increase in the preload and afterload, as well as an increase in the remodeling. So with also a decrease in your or reduction in your cardiac output, your carotid sinus firing will be reduced or slow. There is slowing of the carotid sinus firing. And because of the reduction in your carotid sinus firing, you will have an increase in the sympathetic discharge, causing an increase in the force as well as increase in the heart rate, preload and afterload. The increased force as well as the increase in your cardiac rate and preload and afterload are all compensations in an attempt to increase your cardiac output. So for hypertrophy, this is the most important intrinsic compensatory mechanism. So there is an increase in your muscle mass, which would help maintain the cardiac performance. So initially, it has beneficial effect. So, but however, hypertrophy can lead to ischemic changes, impairment in your diastolic filling, as well as alterations in your ventricular geometry. Remodeling is a term that is applied to dilatation and other slow structural changes that occur in the stressed myocardium. So this includes proliferation of your connective tissue cells, as well as abnormal myocardial cells with some biochemical characteristics of your fetal myocytes. So the myocytes in the failing heart die at an accelerated rate through apoptosis. So the cardiac performance is a function of four primary factors. You have your preload, the afterload, contractility, as well as the heart rate. So Your left ventricular performance, such as stroke volume or stroke work, is plotted as a function of your left ventricular filling, pressure, or end diastolic fiber length. So the resulting curve is called or termed the left ventricular function curve. So this ascending limb represents the classic Frank-Starling. So it should be less than 15 millimeters mercury filling pressure. Beyond this, there is already a plateau of the performance of your cardiac muscle. And preload greater than 20 to 25 millimeters mercury will result in pulmonary congestion. So preload is usually increased in heart failure because of increased blood volume as well as venous tone. And because the function curve of the failing heart is lower, the plateau is reached at a much lower values of your stroke work or output. So an increase in your fiber length or filling pressure increases your oxygen demand in the myocardium. So reduction of your filling pressure is the goal of your salt restriction and diuretic therapy in heart failure. And venodilator drugs also will reduce your preload by redistributing away the blood away from the chest into the peripheral veins. So afterload is the resistance. This is the resistance against which the heart muscle pump and is represented by the aortic impedance and systemic vascular resistance. So as your cardiac output falls in chronic failure, a reflex increase in systemic vascular resistance occurs, mediated in part by increased sympathetic outflow and circulating catecholamines, and by activation of your renin-angiotensin system. So endothelin is also involved, and this is a patent vasoconstrictor peptide. The heart muscle also, when during biopsy, demonstrates in a patient who has heart failure, demonstrates a reduction in the intrinsic contractility. So contractility decreases, and there is also reduction in the velocity of muscle shortening. Meaning to say, di ba kung na-dilate, nauunat, just like your rubber band. So pag unat na, it loss, there is loss of elasticity. So wala nang recoil. So there is reduction. So what happens is you will have a reduction in the velocity of your muscle shortening and the rate of your intraventricular pressure development as well as your stroke output. So although heart is still capable of some increase in contractility in response to your inotropic drugs. So that's why inotropic drugs are also used in heart failure to improve the cardiac performance. So heart rate is a major determinant of cardiac output. So as the intrinsic function of the heart decreases in failure and stroke volume diminishes, you'll have an increase in the heart rate. This is through the sympathetic activation of your adrenoceptors. So this is the first compensatory mechanism to maintain cardiac output. So Digitalis is a drug that is also commonly used in patients who have heart failure. So Digitalis is the genus name for the family of plants that provide most of the medically useful cardiac glycosides like your digoxin. So this, your Digitalis has been known for thousands of years, but were used erratically and with variable success until 1785 when William Withering, an English physician and botanist, published a monograph describing the clinical effects of an extract of the purple foxglove plant. So all of the cardiac glycosides or cardinolides, which digoxin is the prototype, combine a steroid nucleus that is linked to a lacton ring at the 17th position. and a series of sugars at carbon 3 of the nucleus. So it lacks an easily ionizable group, so their solubility is not pH dependent. So digoxin is obtained from Digitalis lanata, which is the white foxglove, but many common plants contain also cardiac glycosides with similar properties. So these plants are your oleander, the lily of the valley, and milkweed. So digoxin is 65 to 80% absorbed after oral administration. So the absorption of other glycosides varies from 0 to near 100%. So it is present in the blood, and your cardiac glycosides are widely distributed to tissues, including the central nervous system. So it's not extensively metabolized in humans, and 2/3 is excreted and changed by the kidney. So its renal clearance is proportional to creatinine clearance, and the half-life is 36 to 40%, 40 hours in patients with normal renal function. So digoxin has multiple direct and indirect cardiovascular effects with both therapeutic and toxic consequences. So it has undesirable effects on the CNS and gut, and at the molecular level, all your therapeutically useful cardiac glycosides will inhibit your sodium-potassium ATPase. This is the membrane-bound transporter, often called as your sodium pump. So if you inhibit this transporter, or inhibition of this transporter is responsible for most of the therapeutic effect of your digoxin, which is positive inotropy, as well as some of the major toxicities of your digitalis. So digoxin or your digitalis will increase the contraction of the cardiac sarcomere by increasing the free calcium concentrations in the vicinity of the contractile proteins during systole. So there are two steps in the increase of your calcium concentration. One is by increasing the intracellular sodium concentration because of sodium-potassium ATPase inhibition. And second, a reduction of your calcium expulsion from the cell by the sodium-calcium exchanger caused by an increase in your intracellular sodium. So the net result of the action of therapeutic concentration of cardiac glycoside is an increase in your cardiac contractility. So digitalis also has effects on your electrical properties. So it's actually a mixture of direct and autonomic actions. The direct actions is on the membranes of your cardiac cells. So it follows a well-defined progression. So you will have an early brief prolongation of the action potential, and then followed by shortening, especially during the plateau phase. So the decrease in your action potential duration is due to the increased potassium conductance that is caused by increased intracellular calcium. So these are some of the major actions of your digitalis on the different cardiac electrical functions. So these are some of the effects caused by your digitalis. So it has an effects on your effective refractory period, the conductance velocity, the automaticity of the different tissues like your atrial muscle, the AV node, as well as your Purkinje system and the ventricles. So each of the effects will have a corresponding ECG abnormalities that will be observed either in the form of an increase in your PR interval or prolongation of your PR interval, a block in your AV node, or it can cause tachycardia or development of your QT, prolongations or shortening of your QT, as well as the development of your premature ventricular contractions, as like bigeminy, which is commonly seen in digitalis toxicity. So at higher concentrations, your resting membrane potential is reduced due to inhibition of the sodium pump and a reduction in your intracellular potassium. Now, as your toxicity progresses, you'll have oscillatory depolarizing after potentials appearing or follows a normally evoked action potentials. So these after potentials, also known as your delayed after depolarizations or your DATs, are actually associated with the overloading of your intracellular calcium stores and oscillations in the free intracellular calcium ion concentrations. So when your after potentials will reach its threshold, they would elicit action potentials. So it's premature depolarizations, or you will see some ectopic beats that are coupled to the preceding normal action potentials. So if you have after potentials in the Purkinje conduction system, you will see bigeminis, meaning to say every after beat you will see every after normal beat or sinus beat, you will see a premature beat, which will be recorded in your ECG. So with further intoxication, each after potential evoked action potential will itself elicit a supra threshold after potential. So you'll see a self-sustaining tachycardia. So this now will cause ventricular tachycardia or even ventricular fibrillation. So this is what I was telling you earlier regarding the occurrence of premature beat every after sinus beat. So this is called as your bigeminy. So this is the sinus beat. So this is your premature beat or premature ventricular beat. So sinus beat, so this is your, so this is seen, this ECG tracing is commonly seen in patients with digitalis toxicity. But you can also see this in other in tachyarrhythmias, not caused by digitalis toxicity. But if your patient is chronically taking digitalis and you see this, baka nagkakaroon na ng digitalis toxicity. So what are the most common cardiac manifestations of digitalis toxicity? So this includes development of your atrioventricular junctional rhythm, premature ventricular depolarizations by geminal rhythm, which was illustrated earlier, your second degree atrioventricular blockade. So cardiac glycosides also has effects on other tissues, including the smooth muscle and your CNS. So in the GIT, this is the most common site of your digitalis toxicity outside the heart, and usually manifestations will include anorexia, nausea, vomiting, and diarrhea. This is actually caused by the direct effects on your GIT and in part by the central nervous system action. On the CNS, you will have vagal and chemoreceptor trigger zone stimulation. So there is disorientation and hallucinations, especially in the elderly. And they will also present with some visual disturbances. So this is manifested as aberrations of your color perception. So gynecomastia is also a rare effect reported in men taking digitalis. So potassium and digitalis interact in two ways. So they may inhibit each other's binding to your sodium-potassium ATPase. Therefore, hyperkalemia reduces the enzyme inhibiting action of cardiac glycosides, whereas hypokalemia facilitates the action, so the opposite. So abnormal cardiac automaticity is inhibited by hyperkalemia. So if you have moderately increased intracellular potassium, this will reduce the effect of your digitalis, especially the toxic effects. So calcium ion facilitates the toxic actions of cardiac glycosides by accelerating the overloading of your intracellular calcium stores that appears to be responsible for digitalis-induced automaticity. So hypercalcemia, therefore, increases the risk of digitalis-induced arrhythmia. So magnesium appear to have an opposite effect to that of your calcium. So other positive inotropic drugs used in heart failure include your extaroxime. So your extaroxime is actually an investigational steroid. So this is an steroid derivative that increases contractility by inhibiting your sodium-potassium ATPase, just like your cardiac glycoside. So it facilitates the sequestration of calcium by the sarcoplasmic reticulum, rendering the drug less arrhythmogenic than digoxin. So drugs also that inhibit your phosphodiesterase, so the family of your enzymes that inactivate your cyclic AMP and cyclic GMP have long been used in the therapy of heart failure. So these drugs have positive inotropic effects, and most of their benefits is due to vasodilatations. So these are your bipedins or inamrinone and your melrinone. So these are the ones which are most successful in heart failure management. So levosimendan is a drug that sensitizes the troponin system to calcium. So it inhibits your phosphodiesterase. It causes vasodilatation and it has an inotropic effect. There are clinical trials suggesting that this drug may be useful also in patients with heart failure. So your bipedins. So your inamrinone is a bipedin. So it's previously called as your amrinone, and melrinones are they are bipedin compounds that inhibit your phosphodiesterase isozyme 3. They are active orally as well as parenterally, but are available only in parenteral form. So the elimination half-life is 3 to 6 hours, with 10 to 40% being excreted in the urine. So the drug would increase the myocardial contractility by increasing the inward calcium flux in the heart during action potential. It may also alter the intracellular movements of calcium by influencing the sarcoplasmic reticulum. So it also has a vasodilating effect by inhibition of your phosphodiesterase, resulting in an increase in your cyclic AMP and an increase in your contractility and vasodilatation. So toxic effects of the drug include nausea and vomiting, development of arrhythmias, thrombocytopenia, and changes in your liver enzymes. So milrinone appears less likely to cause bone marrow and liver toxicity than inamrinone, but it may also cause arrhythmia. Inamrinone and milrinone are also used intravenously, and this is only for acute heart failure or severe exacerbation of a chronic heart failure. So that's the indication. So another important drug for heart failure are your beta adrenoceptor stimulants. So under your beta adenoceptor stimulant is your dobutamine. So it's a selective 1 agonist that has been widely used in patients with heart failure. So it's in a parenteral form, produces also an increase in your cardiac output together with decrease in your ventricular filling pressure. So it may induce tachycardia and increase in myocardial oxygen consumption. But the potential for producing angina or arrhythmias in patients with coronary artery disease is significant because, as I've said earlier, it will cause tachycardia and therefore it will increase your myocardial oxygen consumption. So it may precipitate angina or produce angina and even arrhythmias. So tachyphylaxis may also be observed, and this accompanies with use of other stimulants. Now, intermittent use of your dobutamine infusion may benefit some patients with chronic heart failure. Dopamine is another adrenoceptor stimulant, so this can be used in acute heart failure and may be particularly helpful if there is a need to raise the blood pressure. So drugs without positive inotropic effects are the first-line therapies for chronic heart failure. The drugs most commonly used are your diuretics, your ACE inhibitors, ARBs, aldosterone antagonists, and your beta blockers. So this is beta blocker. So in acute heart failure, diuretics and vasodilators play an important role. So diuretic is the mainstay for heart failure management. It has no direct effect on cardiac contractility. And the major mechanism of action in heart failure is to reduce the venous pressure and ventricular preload. This will result in reduction of your salt and water retention and edema symptoms. It will also reduce the cardiac size, leading to an improvement in your pump efficiency. So spironolactone and eplerinone, they are aldosterone antagonist diuretics. They would decrease morbidity and mortality in patients with severe heart failure who are also receiving ACE inhibitors and other standard therapy. So one mechanism, possible mechanism why it would increase or decrease, the morbidity and mortality is that aldosterone may also cause myocardial and vascular fibrosis and baroreceptor dysfunction. So if you give your aldosterone blocker like spironolactone and eplerinone, this will halt your remodeling, so your vascular fibrosis. So ACE inhibitors like your captopril will reduce the peripheral resistance, thereby reducing also your afterload. They will also reduce salt and water retention and reduce your preload. So it's a balanced dilator, your ACE inhibitors. So if you reduce the tissue and angiotensin levels, will also reduce the sympathetic activity through diminution of your angiotensin's presynaptic effects on your norepinephrine release. So it will reduce also the long-term remodeling of the heart and blood vessels. Your AT1 receptor blockers like your losartan have similar but limited beneficial effects. So they are only considered in patients who are intolerant to ACE inhibitors because of incessant coughing. So this is one of the side effects of your ACE inhibitor, the cough. So in some trials, candesartan was beneficial when added to an ACE inhibitor. Aliskiren is a renin inhibitor that is recently approved for hypertension, but this is still on clinical trials for heart failure. So, but preliminary results suggest that the efficacy is similar to that of your ACE inhibitor. So vasodilators are also effective in acute heart failure because they provide a reduction in your preload or a reduction in afterload. So with long-term use of hydralazine and isosorbide dinitrate, this can also reduce the damaging remodeling of the heart. Your naseritide brain natriuretic peptide, or your BNP. They are synthetic form of endogenous peptide and is approved for use in acute cardiac failure. It increases your cyclic GMP in the smooth muscle cells and reduces venous and arteriolar tone. It can also cause diuresis, but it has a short half-life of only 18 minutes. So it's administered as a bolus intravenous dose followed by continuous infusions. So most of the common adverse effect of your necessary is excessive hypotension. So plasma concentrations of your endogenous BNP rise in most patients with heart failure, and they are correlated with severity. So measurement of your plasma BNP has become a useful diagnostic and prognostic tool in patients with heart failure. So you have also your related peptides, which are also used in heart failure. So these are your atrial natriuretic peptide, or your ANP, and your urodilatin, which has a similar peptide produced by the kidney. So your carperitide and ularitide are investigational synthetic analogs of these endogenous peptides, and they are still there's an ongoing clinical trial with these two investigational analogs, synthetic analogs. So your bosentan and pezosentan, they are orally active competitive inhibitors of your endothelin. So they have been shown to have some benefits in experimental animal models with heart failure, but results in human trials have been disappointing. So bosentan is approved only for use in pulmonary hypertension. So it has a significant teratogenic and hepatotoxic effects. Then you have your beta adenoceptor blockers. So for chronic heart failure, they will respond favorably to certain blockers, in spite of the fact that these drugs can also precipitate acute decompensation of cardiac function. However, there are already studies with bisoprolol, carvedilol, and metoprolol showing a reduction in mortality in patients who have given with these medications with stable severe heart failure. So the mechanism here include attenuation of the adverse effects of high concentrations of your catecholamines and upregulation of receptors, decreased heart rate, and reduced remodeling through inhibition of mitogenic activity of your catecholamines. So there are 4 stages in the development of heart failure based on the American College of Cardiology and the American Heart Association guideline for the management of chronic heart failure. So you have A to D, A, B, C, D. A, these are high-risk patients because of other disease but have no signs or symptoms of heart failure. And stage B, they are patients that has evidence of structural heart disease, but they don't have the symptoms of heart failure. So stage C, these are patients who already have structural heart disease as well as symptoms of heart failure. But the symptoms here are still responsive to ordinary therapy. And stage D are actually, these are intractable CHF na patients who have heart failure, refractory to ordinary therapy, and special interventions are required, like your resynchronization therapy or the use of your left ventricular devices to improve the cardiac output. So once you are in stage C, severity of heart failure is described according to a scale devised by the New York Heart Association. So you have your functional class 1, 2, 3, and 4. When we say class 1, this is associated with no limitations on ordinary activities, and symptoms occur only with greater than ordinary exercise. Class 2 is characterized by slight limitation of ordinary activities, which result in fatigue and palpitations with ordinary physical activity. And class 3 results in no symptoms at rest, but fatigue, shortness of breath, and tachycardia occur with less than ordinary physical activity. And class 4 is associated with symptoms even when the patient is at rest. So for chronic heart failure, there are the major steps in the management are actually outlined in your book. So there's a table there, table 13.3. So in the ACCHA 2005 guidelines suggest that treatment of patients at high risk should be focused on the control of your hypertension, hyperlipidemia, and diabetes if this is present. So this is the table for the prevention and treatment of chronic heart failure. So you have the different steps here and the classification. So for stage A and B, so important step here is to control hypertension if this is present, because these are the risk factors: hypertension, hyperlipidemia, the diabetes, as well as obesity. Once the patient is already on C, so they are already symptomatic, so you need to reduce the workload of the heart. So you limit the activity, you put the patient on temporary bed rest, you restrict their sodium intake, and you give diuretics to decongest your patients. You also restrict their fluid intake. And for C and D, you now can give your drugs for heart failure, like your angiotensin converting enzyme inhibitors, your ACE inhibitors, or your ARB. So Digitalis can also be given if you have already systolic dysfunction. So you will know whether there is already systolic dysfunction because you will hear a third heart sound. So there is already gallop rhythm, and fibrillation, atrial fibrillation may also be present. Then you can also give your beta blockers, especially kung stable lang yung heart failure. But in acute heart failure, you do not give your beta blockers. Then you can also give your aldosterone antagonists as well as your vasodilators. For stage D, since these are intractable CHF already, they may need some devices to improve the cardiac function. So they may need to undergo cardiac resynchronization therapy